We're going to take a couple of examples on how to implement these theories. They are general examples in addition to the case that we've just discussed. The first example is the informed consent. The informed consent, again, have many definitions, but as we mentioned before, it is an autonomous authorization of a medical intervention by individual patient or participant in case of research. This is how we express our respect to the patient's right to autonomy and to his or her personality. So the process of informed consent is a process of communication, of a shared decision-making process between the researcher and the participant, or between the care provider and the patient. For informed consent to be valid, there are three main conditions. In the literature you can find more than three, but let's focus on those three: disclosure, voluntariness, and capacity. By disclosure, this refers to the process during which the healthcare provider or the researcher provides information about the proposed intervention or research to the participant or to the patient. So basically you need to provide the information to your patient or to the research participants in a language and format that is readily understandable by the patient. The capacity refers to the presence of a group or set of functional abilities. That's to say that we need to make sure that the person we are dealing with, we are giving the information to, is able to take a decision. In order to assess this ability to take the decision, i.e. to have the capacity, there are two main factors or two main things that we need to assess. First is the person's ability to understand the relevant information that are being given to him. The second is to appreciate the relatively foreseeable consequences of various available options. For example here, that there are some participants who can understand but cannot appreciate. Okay, yes, children, for example, they can understand the kind of information that we can tell them if it's said simple enough. However, their ability to appreciate the risk associated with a surgery or a trial is not, they cannot appreciate it. So their ability or their capacity to take such decisions is diminished, and therefore we tend to have the parental consent or the guardian's consent. The third, which is very important, is about the voluntariness. Voluntariness, we need to make sure that the participant right is to make the decision, is that the decision is taken free from any undue influence. This undue influence could be physical force, which is quite unlikely. However, it could include money, for example, paying for the patients to accept a certain intervention, or paying for the people to accept a certain intervention or to be involved in kind of research. There is another kind of undue influence, especially in our region, which is related to the hierarchy within the family. For example, a woman might be forced to accept to be a part of an intervention or a part of research because of her husband being around, or because the community leader told them to do so. The second example is about the rationing and resource allocation. Okay, I'm almost 40 and this is my birthday cake, and this is exercise, just share it fairly. Think about it for 1 minute and what could be the ways to divide this among ourselves. Any ideas? Okay. If we apply the theories in terms of distributing the public health, the resources being allocated to less expensive treatment or services that provide the greatest benefit, so that if we have a given amount of resources, so that we need to invest them, so that choose the less expensive that have the greater benefit. In terms of public health, like for example, the treated mosquito net as a preventive measure of malaria, it's fairly less expensive, and it provides more protection for more people. If we're talking about equity and distributive justice, the theory says that equals should be treated equally and equals should be treated unequally in proportion to the relevant inequalities. Put it simple, that there are inequalities among most of our countries. There are rural areas with poor access to health, while there are other urban areas with better access to health and better income and more choices. So that if we have resources, we need to give priority to those who are relatively in a less fortunate position, for example. There is issues of autonomy. So basically one would say that let the people choose what is in their best interest. If we're applying the issue of harm or benefit, or the beneficence, non-beneficence, healthcare providers should act in the interest of their clients or patients and not to harm them. So when we are allocating the resources, we need to make sure that we are helping the people and not harming them. There is issues of justice or fairness. All groups have an equal right to health services regardless of their age, gender, age, income, or any other characteristics. However, as we've just mentioned, for the vulnerable people or the vulnerable population in the population, perhaps they may need to be given priority just to make sure that it's fair. So basically, to be fair is not necessarily to be equal. There are two models for the resource allocation. First is by Emanuel, and the second by Sabin and Daniels. So, what Emanuel says about justice and managed care, as he calls it, so improving health should be the primary goal of the public health intervention. The allocation of health resources should aim at and be justified by the improvement of the people's health. So this is the primary goal. Second is, patients and members should be informed. This is very important again. It brings us to the informed consent example that we've just mentioned a few slides ago. So the patients of the community should be informed about the allocation of the health care resources and the underlying data and justifying for such allocation. So people should know why we are going to give this resource to this region and not to that region. Patients and members should have the opportunity to consent, so that we should have some sort of a community consent or even the individual consent. Conflict of interest should be minimized. Conflict of interest basically refers to when we have interest in the outcome of the intervention that we are doing. It could be financial, so that if, for example, if a company gives us an equipment and says that if you distribute or a drug or a vaccine, they say if you distribute it, I'll give you a percentage out of the revenues of this equipment or this vaccine. We need to minimize this kind of conflicts of interest. Daniel Sabin said that there are 4 conditions if in any resource allocation process, if this resource allocation process fulfills these 4 conditions, then it is morally defendable. The first is the relevance, so that the priority setting decision must rest on reasons. Basically, we're talking about evidence and principles that most of the stakeholders can agree that they are relevant. This could include the managers, clinicians, patients, and the community in general. So it should be relevant to those people. When allocating the resources, they should be relevant to them. Second is the publicity, so that the priority setting decisions and their rationale must be publicly accessible through the website of the Minister of Health, for example, through pamphlets, through the news papers, through whatever kind of making, so that anyone who wants to know how much is allocated for this particular resource and who receives it, then it will be available to him or to her. The third is to appease. Appease meaning that if someone is not satisfied or not convinced with the resource allocation process, then there should be a mechanism so that the decisions that are taken could be revised in terms in the light of further evidence or principles. And this fourth is the enforcement. There must be voluntary or public regulation of the process to ensure that the first 3 conditions are met. I know that this could be very idealistic in many conditions in our region, because unfortunately, the distribution of the resources depends on political decisions, not on evidence. For example, or more community leaders are more powerful than other community leaders, so they bring more resources to their communities. The issue of publicity and the issue of transparency, and unfortunately many of our countries are kind of not very much into transparency. And these are challenges that we need to address, but at least in this course we're studying the standard that we need to be followed. Let me finish with this example. Within its effort to control the spread of pandemic influenza A, H1N1, during high season in 2010, the federal government was able to provide a total of 2,500,000 doses of the newly produced vaccine. The pilgrimage are estimated to be 3,500,000. The working staff in contact with the pilgrims, like the entry officers, the security officers, and the health personnel, are about 120,000 persons. Let's have a thought, and we can submit that later on in an assignment. Who should have the vaccine, and who is first, and how can we justify the allocation of these vaccines?